Continuing on with our discussion of motion as the central part of our network of meaning or our semantic network for our understanding of anatomy, especially with respect to assessing and treating for osteopathic purposes, we're going to look at wrist deviation. Now, the reason we use the term wrist deviation is because we're going to talk about both abduction and adduction essentially as a joint concept. So we're going to call it wrist deviation. Now, our main objectives is to discuss what wrist deviation is, so which planes and axes these motions occur in, the abduction and adduction, the general discussion of the muscles that deviate the wrist, general discussion of the nerves that supply those muscles, the arteries specifically that supply those muscles, or maybe generally, less so the veins, and then a general discussion of the areas to assess and treat should wrist deviation issues be suspected by the practitioner or reported by the patient. So our common discussion of planes, so the sagittal plane is a 50% cut of the body back to front, or sorry, I definitely made a mistake there. Sagittal plane, 50% of cut of the body left to right. The horizontal or transverse plane, 50% cut of the body top to bottom. The frontal or coronal plane is a 50% cut of the body back to front. The axes are perpendicular to the plane, so the sagittal plane has a horizontal or transverse axis. The horizontal or transverse plane has a vertical axis. The frontal plane or the coronal plane has an AP or a PA axis. Now, in the case of wrist deviation, both abduction or movement of a body part away from the midline and adduction, movement of the body part towards the midline, are both going to occur in the frontal or the coronal plane about a relative anterior, posterior, anterior axis. Now, in the case of radiocarpal or wrist deviation, talking about the proximal row of carpals in relation to the distal radius primarily, there is nothing that is going to pin that anterior to posterior or posterior to anterior. So this is essentially a hypothetical axis. The axis is determined by both the relationship between these bones as well as the muscles that are going to generate this motion. So there's no actual AP or PA axis here. It's hypothetical or it's inferred, right? But the motion that we're talking about now, my hands, the abduction is going to be, and adduction as terms are going to be in relation to the anatomical position, which is the arms at the side, thumbs out, palms up. So I can't show you that because if I show you my palms, my thumbs are in. But essentially, abduction is movement away from the midline, whereas adduction is movement towards the midline. You can also call the abduction movement away from the midline, you can call that radial deviation, and the adduction you can call ulnar deviation, right? And again, these are occurring in the coronal plane about a hypothetical AP or PA axis. Now, the muscles that are going to generate primarily and I'll show you both cuts here, right? So we've got the anterior surface and the posterior surface because there's muscles that are going to generate this. The muscles that are going to generate the abduction are going to have generally radius attached to them. So if it's a radial muscle, anterior or posterior surface, or anterior or posterior compartment, you're talking about a radial deviator, very, very broadly speaking. Also, abductor pollicis longus, or abductor pollicis is also going to help generate some radial deviation or some abduction. And then if it has ulnar or ulnaris attached to the name of the muscle, then it's going to be an ulnar deviator. That's the simplest way to do this. And again, instead of picking apart all of the terms or all of the names of the muscles, generally speaking, if it's got radial on it or radialis, it's going to be a radial deviator or an abductor. If it's got ulnaris, it's going to be an ulnar deviator or an adductor of the radiocarpal joint. All right, now the neurovascular bundle, so we'll just show both cuts so that you can see this, but the neurovascular bundle, especially with anything that's going to be contained, be it ulnar or radial deviator in the posterior compartment of the forearm, then you're thinking about the radial nerve or its branch, the posterior interosseous nerve. If you're in the anterior compartment, then you're thinking radial nerve, median nerve, or anterior interosseous nerve, depending on the particular deal. But if it's going to be a radial deviator, a little bit more likely to be the radial nerve. If it's going to be an ulnar deviator, a little bit more likely to be the median nerve, or in some cases, the anterior interosseous, right? You're going to have some variation there, but the important things are to note that the neurovascular bundle is going to be both sides, both anterior and posterior compartment of the arm and anterior and posterior compartment of the forearm, right? Depending on which particular muscle you're considering or which particular motion you're considering, it may be more posterior for nerve, maybe, especially if it's going to be on the posterior compartment. But in the case of radial or ulnar deviation, you're going to have muscles that are in both compartments generating the radial or ulnar deviation. So you're realistically primarily considering anterior and posterior surfaces of the arm, anterior and posterior surfaces of the forearm, along with the motions themselves based on how these neurovascular bundles are going to run. And as we'll discuss in the areas to assess and treat, as with anything else with the arm, anywhere you're coming neck, clavicle, axilla, and then in this case, anterior and posterior surface of the arm, anterior posterior surface of the forearm. So as we already noted, based on the neurovascular bundles, you're going to consider the cervical column, you're going to consider the clavicle and the axilla, you're going to consider the anterior soft tissues and the posterior soft tissues of the arm. Again, neurovascular bundles, the posterior soft tissues of the forearm, as well as the anterior soft tissues of the forearm. Even though it doesn't say anterior there, you're going to be considering the anterior surface or soft tissues of the forearm as well. So with ulnar or radial deviation issues, you're most likely to be considering the neck, the clavicle, the axilla, and essentially all the soft tissues of the arm, as well as the motion itself. Again, once you get away from the appendicular scale or the axial skeleton, you get more in the appendicular region, your contraindications and red flags tend to minimize as long as there isn't the presence of a general contraindication or red flag that would be identifiable as, say, the patient presents and there's rebound tenderness of the abdomen. That's an immediate referral, or any changes in cognition or memory or speech, then that's an immediate referral. But if the issue happens to be deviation of the wrist, be it radial deviation, aka abduction, or ulnar deviation, aka adduction, you're less likely to see those things. You're more likely to see contraindications and red flags that would take the form of a known fracture or tear, which you don't treat because you can cause further damage, or a suspected fracture or tear, which you refer out for either confirmation or a differential diagnosis at a level that you as a hands-on practitioner are not able to perform accurately or meaningfully, such that you utilize the skills of other practitioners to make sure that it is safe to treat the area. Now, in the case of a known or suspected fracture or tear, you can treat the patient. You don't treat this particular area where that known or suspected fracture or tear is, because you can cause further damage until you know otherwise. So if it's a known fracture or tear, you don't treat it on account of the fact that you can cause further damage. If it is a suspected fracture or tear, it's referral out based on information that comes back from the further diagnostic. You can then make a choice. If there is a known fracture, it's don't treat. If there is no fracture and no tear, you can enter the area cautiously.